Yeah, so one of the areas that I'm very interested in is that patients with Notch1 mutations do not benefit from the addition of Rituximab to the chemoimmunotherapy backbone, and that's been shown by, so it's anti-CD20 therapy really, so it's been shown by the complement study where the antibody was ofatumumab, and then by the German CLL study. There's also biological evidence showing that patients with Notch1 mutations do not express as much CD20 on the cell surface. So it makes biologically sense that the anti-CD20 antibody doesn't work, doesn't have an effect in those patients. Yet we give everybody Rituximab or ofatumumab or obinutuzumab, and that's 14% of patients with Notch1 mutations have got those in frontline. There's another few percent with mutations in the non-coding region of Notch1 that also have an impact on Notch1 activity and lead to constitutive activation of Notch1. So overall, you could argue that if we had more extensive sequencing happening across Notch1, we would be able probably to save 20% of anti-CD20 antibody use. I mean, that's very provocative for me to say that, but it's something I think that we need to get used to, because we also can't prove all these findings in every single biomarker and prospectively randomized controlled clinical trials. We have to put biological evidence and evidence from subgroup analysis together and then basically come up with what is the best way forward, pragmatically speaking. So that's I think one of the examples where I think the sequencing would have an impact beyond TP53 in CLL.